Slide 1. This slide tape is one of a series of presentations in renal pathophysiology prepared by the American Physiological Society. 2. The program begins with a review of prerequisite knowledge. Before you go any further, make sure you have completed the entry skills test provided in the study guide. 3. During the presentation, question slides will appear at intervals. Stop the tape to answer the questions. Then advance to the next slide on which the correct answer will appear. Stop the tape again to check your answer. After you finish the unit, assess your understanding of the material by taking the post-test in the study guide. 4. The subject of this discussion is edema. Content expert, Dr. C.H. Coggins. 5. We will discuss the following topics. First, the definition and description of edema formation. Second, physiological forces which move fluids into and out of capillaries. Third, mechanisms for and clinical circumstances in which imbalance of forces occurs. Fourth, renal mechanisms in normal and abnormal salt retention. 6. Your first objective is to be able to 1. Define edema. 2. State the determinants of generalized edema formation. And 3. List 3 clinical circumstances in which generalized edema occurs and 3 in which localized edema occurs. 7. Total body water is distributed in 3 anatomically separable compartments. 2/3 is found in the intracellular fluid and 1/3 in the extracellular fluid. The extracellular fluid compartment is subdivided, 1/5 into plasma and 4/5 into the interstitial fluid. 8. Edema is a localized or generalized abnormal expansion of the interstitial space. Clinically, edema is the visible, palpable swelling resulting from this expansion. 9. A localized area of edema requires that fluid move from the intravascular space across the capillary wall into the interstitial space. 10. Localized edema is frequently seen in 1. Burns, 2. Trauma, 3. Allergic reactions, and 4. Inflammation or obstruction of flow through veins or lymphatics. 11. Generalized edema requires not only the abnormal movement of fluid out of the capillaries of the vascular system, but also retention of salt and water by the kidneys. The retention of salt water becomes obvious when it is realized that there may be only 2.5 to 3 liters of plasma water in the entire vascular tree, while patients frequently have 10, 15, or more liters of edema fluid in addition to the expected volume of interstitial fluid. 12. Generalized edema is a common manifestation of 1. Nephrotic syndrome, 2. Cirrhosis of the liver, 3. Congestive heart failure, or 4. Malnutrition. 13. Remember to stop the tape to answer questions and to check your answers. 14. 15. 16. 17. The mechanisms of edema formation involve both the capillaries and the kidneys. We shall consider the normal function of the capillaries and the kidneys separately, although they function simultaneously in practice. 18. After completing the next section on capillary mechanisms in the normal individual, you should be able to 1. List 3 determinants of the average hydrostatic pressure gradient forcing fluid out of the capillaries. 2. State the principal mechanism by which fluid is reabsorbed into the capillaries. 19. In normal capillary function, the distribution of fluid between the plasma and interstitial space is governed by the Starling forces balancing hydraulic and osmotic force differences. 20. The first factor determining hydrostatic pressure and tending to force fluid out of the capillaries is the rate of blood flow through the capillaries. This is largely controlled by 1. Precapillary resistance, and 2. Variable flow of blood within a network. Some vessels tend to be dilated with high flows and some constricted with low flows at any given time. Therefore, the hydrostatic pressure is not the same in all capillaries of a local network. 21. The second factor determining hydrostatic pressure is the pressure drop between the arteriolar and venous ends. In this instance, the hydrostatic pressure, which tends to force water out of the capillary, is governed by 1. Capillary length, 2. Capillary resistance to flow, and 3. The hydrostatic pressure in the veins into which the capillary is emptying. 22. The third factor which determines hydrostatic pressure is the pressure of the interstitial space, which is much less than that within the capillary. This pressure has proved difficult to measure, and whether it is positive or negative with respect to atmospheric pressure is not certain. 23. To recapitulate, in determining the average hydrostatic pressure gradient across the capillary, we recognize 1. The blood flow rate and variability of flow through the capillaries of a network. 2. The drop in hydrostatic pressure from arteriolar to venous end along the length of the capillary. And 3. A hydrostatic pressure in the interstitial space of uncertain magnitude. These factors, determining the average hydrostatic pressure gradient, tend to move fluid out of the capillaries. 24. The hydrostatic force tending to move fluid out of the capillaries is opposed by an osmotic force which tends to move fluid into the capillaries. This osmotic force is attributable to solute particles within the plasma, which cannot move freely through the capillary membrane. 25. The osmotic force resulting from these solute particles promotes reabsorption of fluid into the capillary and is called oncotic pressure. The non-diffusible osmotically active particles are the plasma proteins and some associated charged ions. Movement of these ions is restricted because of the electric charge on the protein molecules. 26. Albumin is by far the most important contributor to oncotic pressure by virtue of its great abundance and small molecular size. Compared to other plasma proteins, the small size allows for more molecules per gram. The blood contains about 5 grams of albumin per 100 milliliters of plasma. 27. The protein concentration of the interstitial fluid is much less than that of plasma. Therefore, there is a tendency to return fluid from the interstitial space to the capillary. This oncotic pressure gradient is about the same at the arteriolar and venous ends of the capillary. 28. Normally, there is an imbalance between the average capillary hydrostatic and oncotic pressures, leading to a slight average movement of fluid out of the capillaries. This fluid is returned as lymph to the circulation. 29. 30. 31. After completing this section, you should be able to 1. Identify 4 mechanisms in which an imbalance occurs between hydrostatic and oncotic pressure, causing an expansion of the interstitial space. 2. Give the etiology of edema formation for each listed example. And 3. Identify the mechanism by which expansion of the interstitial space stops. 32. The interstitial fluid space would be expected to expand abnormally to produce edema if 1. An imbalance in the Starling forces favored an increased outward movement of fluid from the capillary, or 2. If the return of lymph to the circulation were impaired. Some examples of mechanisms in which this imbalance often occurs are shown on the following slides. 33. The first mechanism in which an imbalance between hydrostatic and oncotic pressure occurs is an increase in hydrostatic pressure. Increased capillary hydrostatic pressure will occur when there is 1. An increased hydrostatic pressure in the venous bed draining the capillary network, or 2. An increased blood flow through a capillary network. 34. Increase in the hydrostatic pressure of the venous bed draining the capillary network may be a result of 1. Increased right ventricular end diastolic pressure in heart failure, 2. Obstruction by thrombosis or external pressure on the veins, or 3. Gravity, which with prolonged standing or incompetent valves produces increased pressure in the veins of the feet and legs. 35. Increased hydrostatic pressure due to increased blood flow through a capillary network will occur locally with infection or inflammation. 36. The second mechanism in which an imbalance occurs is a decreased oncotic force in the vascular fluid. The imbalance will lead to a decreased return of fluid into the capillaries with the gradual accumulation of edema. 37. Decreased oncotic force may result from 1. A decreased serum albumin caused by either urinary losses of protein, as in the nephrotic syndrome, or, uncommonly, by losses of protein from the gastrointestinal tract. And 2. From decreased synthesis of albumin, as in liver disease, and protein malnutrition, kwashiorkor. 38. The third mechanism in which imbalance occurs is a loss of oncotic pressure gradient, which may be due to abnormal permeability of the capillary wall, or, in addition, the increase of proteins in the interstitial space. As the wall becomes increasingly permeable to proteins, these molecules will no longer generate an effective osmotic force across the capillary membrane. Concomitantly, the interstitial oncotic pressure rises. Both the protein leak and change in oncotic forces allow less fluid to filter back into the capillary, with resulting accumulation of edema. 39. Either abnormal permeability of the capillary wall to protein or abnormal permeability plus increase of proteins in the interstitial space may result from 1. Burn, 2. Trauma, and 3. Inflammation or allergic reactions. 40. The fourth mechanism in which an imbalance between hydrostatic and oncotic pressure occurs is an obstruction of the lymphatics, as found, for example, in filariasis. This leads to the accumulation of fluid and of small quantities of protein that are normally filtered, leading to expansion of the interstitial space and edema formation. 41. Increasing expansion of the interstitial space is due to increased hydrostatic pressure, decreased oncotic pressure in the vascular fluid, increased oncotic pressure in the interstitial fluid, or obstruction of the lymphatics. At what point will this increasing expansion stop? As the interstitial space expands with the formation of edema, the hydrostatic pressure gradient across the capillary membrane decreases. Therefore, the imbalance in Starling forces will tend to be corrected and a new steady state achieved. 42. 43. 44, 45, 46, 47, 48, 49, 50. After completing the next section on renal mechanisms, you should be able to 1. Identify two well-understood processes responsible for salt retention in the normal individual, and 2. State the mechanisms for each. 51. As already mentioned, when edema is generalized, the expansion of the interstitial space by several liters implies a large increase in total body content of salt and water. This means that renal mechanisms must have been responsible for retaining an unusual quantity of salt and water. 52. In a normal person, salt retention is the result of a salt deficit. The deficit leads to a prompt reduction of salt excretion by the kidneys, so that dietary salt is retained and the deficit is rapidly corrected. 53. Salt excretion by the kidneys can be reduced by reduction in the quantity of salt filtered at the glomerulus, or by an increase in the proportion of filtered salt which is reabsorbed into the blood. These two processes are well understood. While both play a role in the regulation of salt excretion, changes in reabsorption appear to be much more important than changes in filtration. 54. The first mechanism, the reduction of salt filtered at the glomerulus, results from a decreased glomerular filtration rate. With salt deficit, the extracellular fluid volume is contracted. This leads to decreased return of venous blood to the heart, and hence to reduced cardiac output and blood pressure. With the resulting decrease in renal blood flow, glomerular filtration rate, and hence the quantity of salt filtered, will be reduced. 55. The second and principal mechanism, increased salt reabsorption, results from the release of aldosterone. Reduction in the pressure of the blood perfusing the kidneys is sensed by stretch receptors in the walls of the afferent arterioles of the glomerulus, the juxtaglomerular apparatus, through the sympathetic nervous system. This causes release of the enzyme renin. An increased reabsorption of sodium in the distal tubule results through the renin-angiotensin-aldosterone mechanism. 56. Other mechanisms by which the kidneys reduce salt excretion are not so well understood. For instance, the proximal tubule and loop of Henle and collecting tubule seem to reabsorb an increased quantity of salt in states of intense salt conservation. Also, a redistribution of intrarenal blood flow away from the outer cortex may occur. 57. The stimuli leading to the increased reabsorption in the tubule and the redistribution of renal blood flow may include stimulation of the sympathetic nerves supplying the kidneys, or the presence of a circulating hormone influencing salt reabsorption in the renal tubules. 58. 59. 60. 61. As your last objective, you should be able to 1. Identify the difference between salt retention in the normal and the edematous individual, and 2. Suggest 2 possible courses of treatment for edema. 62. In the normal individual, a salt deficit results in a contracted extracellular fluid volume. Salt retention restores the extracellular fluid volume to normal. 63. In the edematous patient, salt is retained as a result of an underlying disease, not as a result of a salt deficit. Usually, the body is unable to correct the underlying problem. Since the extracellular fluid volume is initially normal, the tendency to retain salt, and therefore to retain water, may result in a vast expansion of the interstitial space. 64. The abnormalities leading to salt retention are often very apparent. In the patient with nephrotic syndrome, the urinary loss of protein, proteinuria, leads to hypoalbuminemia with reduced plasma oncotic pressure. The reduced plasma volume results in lowered cardiac output and lowered renal perfusion, which in turn result in salt retention. 65. Similarly, in a patient with heart disease, a reduced cardiac output may lead to salt retention. 66. The patient with severe liver disease or malnutrition may also have hypoalbuminemia, producing the same effects. 67. Salt retention in the edematous patient is due to a combination of mechanisms, some well understood and others not well understood. In these patients, there are no known physiological compensatory mechanisms for restoring salt balance. It is apparent that the most effective treatment would be to correct the underlying abnormalities, proteinuria, heart failure, liver disease, malnutrition, or whatever. When this is not possible, diuretics may be used. 68. A discussion of diuretics can be found in the following reference. 69. 70. 71. 72. 73. This concludes the discussion of edema. Refer to your study guide for the post-test and references for additional reading.